Hello online students, I'm going to be recording the ABG section. This is going to be fun. I don't know if I've convinced you of that yet, but it's going to be fun. All right, let's get started. Having some fun. If you will make sure before we start, if you need to pause this, make sure you have your Med-Surg book out, open to chapter 12. Make sure you have downloaded your article, Tic-Tac-Toe Child's Play. And make sure you have downloaded your 2 handouts that are on there. So download everything so that you can follow along with me in your PowerPoint. I've also posted my PowerPoint with and without note pages to help you as well. Alrighty then. So we're going to be talking about acid-base imbalances. I know when I first started teaching, I told you're going to do acid-base imbalances. And I almost had an acid-base imbalance from all the diarrhea. But it turns out that I dug and found good resources, and I understand it completely, and hopefully I can help you understand and even like and enjoy learning about acid-base imbalances. So your reading assignment is your Med-Surg book chapter 12, which is short and sweet. Article, Turning ABGs into Child's Play. Lab book chapter 6 and handouts. Activities, we're going to do some lecture and discussion, PowerPoint slides, Miss Candler's, believe it or not, instead of Ripley's, believe it or not, and some critical thinking activities via the website. You do not have to do these, but I have posted you a couple study stacks up in another website that's really good. And I've also posted some brain teasers to see if you really understand and grasp the concept of acid-base imbalance, because there's more than just interpreting the ABGs, which I think all of you will do quite well on that section. So let's start with some Miss Candler's believe it or not, okay? So if you believe the statement when I say it, stand up. If you don't believe it, stay seated. If you're not sure, go halfway. So you want to make sure when you're doing this that your family's not around. They may think you're little nuts getting up and down. So you might want to do this in private. Okay, again, if you believe the statement is true, stand up. If you believe the statement is false, stay seated. And if you're not sure, go halfway. Here we go. Number 1. Oops, let me go back here to the previous. Okay, number 1. Normal, and if you have downloaded my PowerPoint with and without notes, it is on my notes. Normal pulmonary function requires a balanced relationship among the respiratory, the cardiovascular, the nervous, and renal systems. True or false? The answer to that was true. You should be in the standing position. Number 2, carbonic acid concentration is maintained by the kidneys. Number 2, carbonic acid concentration is maintained by the kidneys. That is false. You should stay seated. It is by the lungs. Number 3, normal pH is 7.35 to 7.45. 7.35 to 7.45. And the answer to that is true. You should be standing. Number 4, I can't count. The normal PaCO2, so your CO2 level, is 35 to 45. The normal CO2 is 35 to 45. That is true. You should be standing. Normal bicarb is 20 to 30 milliequivalents per liter. Normal bicarb is 20 to 30 milliequivalents per liter. And the answer to that is false. You should be seated. For purposes of this exam, we're going to go by 22 to 26. And I know your book says something a little different, but we're going by 22 to 26 normal bicarb, because that's what the majority of your resources out there will say the norm is. One of the things that's always upset me about nursing is that we have potassium levels that can be 5 different norms depending upon where you work and what book you look in. To me, potassium norm should be one for all. There should be a universal potassium norm, but that wasn't my doing. Number 6, when the kidneys fail, the resulting imbalance is metabolic. When the kidneys fail, the resulting imbalance is metabolic. And that answer was true. You should be standing. Number 7, the carbonic acid bicarbonate buffer system is the major buffer system of the body. The carbonic acid bicarbonate buffer system is the major buffer system of the body. And the answer to that is true. You should be standing. Number 8, if the pH drops below 7 or raises above 8, death usually occurs. If the pH drops below 7 or raises above 8, death usually occurs. And the answer to that is true. You should be standing. Number 9, the O2 level only indicates how well the patient is obtaining oxygen and does not indicate the acid-base status. The O2 only indicates how well, or oxygen level, the patient is obtaining oxygen and does not indicate the acid-base status. That is true. You should be standing. The major effect of alkalosis, number 10, on the central nervous system is depression. The major effect of alkalosis on the central nervous system is depression. And the answer to that is false. You should be seated. The answer should be the major effect of alkalosis on the central nervous system is stimulation. All right. So again, if you have printed out my PowerPoint with notes, you will find all of those questions and you will find all the answers on the next PowerPoint. Hope that had some fun. We got a little activity in there too. Remember, the measurement of blood gases is considered one of the most valuable diagnostic tools, whether we're taking care of a child or an adult who's in respiratory distress or impending cardiopulmonary failure. So it is one of the main things that's going to tell us how they are doing as far as acid-base exchange and if there's any imbalance occurring. All right, so what is your role as an RN in dealing with patients who have acid-base imbalance? Number 1, you're going to have to, as an RN, be able to recognize situations that are likely to cause an imbalance to start with. In fact, they did a study of 110 random admissions in a hospital, and it revealed that 56% of those patients had some type of acid-base imbalance. So most patients, even those that you don't come in with an imbalance, actually have some type of imbalance. So chances are you will take care of a patient who has one of those. Number 2, help to prevent imbalances from occurring. As an RN, if you know patients who are prone to have certain imbalances, you can actually prevent them from occurring. If you know someone, for example, has panic disorder, then if you let them sit there and hyperventilate, they're going to go into respiratory alkalosis. But if you prevent them from getting to that point by calming measures, medication, whatever it takes, you can actually prevent them from going into full-blown respiratory alkalosis. Number 3, carrying out orders and monitoring for response. That's always been an RN responsibility. Not only do we do the orders, but we always have to monitor and assess the response. And number 4, finally, knowing the signs and symptoms of acid-base imbalances. There's only 4 major imbalances of the body, and you do need to know the major signs and symptoms of alkalosis versus acidosis, and we'll be discussing those when we talk about the actual imbalances. So, what are the systems affecting acid-base imbalance or acid-base balance? The primary function of the respiratory system we know is to supply oxygen to the blood cells and remove carbon dioxide. So this normal pulmonary function requires a balance between 4 systems: respiratory, cardiovascular, nervous, and renal. That was one of our true-false questions, and the answer was true. So respiratory, cardiovascular, nervous, and renal systems all have to be intact. So let's talk about the nervous system. The brain, we know, sends out and receives stimuli that helps maintain the balance of oxygen uptake and carbon dioxide elimination. We know the medulla and the pons are major brain centers that affect respiration. And we know the medulla is the center for spontaneous respiration. So we have to have an intact nervous system to be able to send signals between the medulla and the pons to make sure that we have respirations intact. The cardiovascular system pumps oxygenated blood from the left side of the heart to the blood organs, tissues, and cells. We know that it's very important in circulation, particularly of the red blood cells, and it helps keep us oxygenated to our tissues and our cells, and very, very important. The renal system is very, very important to the acid-base balance. It helps regulate in an attempt to maintain homeostasis or balance through selective filtration and reabsorption. And we'll talk about that here in a little bit, because what it does is either helps us increase or decrease the acidity of urine, therefore bringing us back into balance. So if you don't get anything else, you got to get this. Acid-base balance is mainly regulated by two of those four systems, and that would be the respiratory and the renal. Now, you also have to have an intact cardiovascular and a nervous, but the respiratory and the renal are your major systems. So, carbonic acid is measured in the form of CO2 because we cannot measure it directly, so we measure it indirectly at the metabolite. So, carbonic acid is measured in the form of CO2. CO2. It is maintained by the lungs. The lungs. So think respiratory when you see carbonic acid, because that's your acid component of the acid-base imbalance or balance. So when you see carbonic acid, think CO2, think lungs. Carbonic acid, CO2, lungs, respiratory. Carbonic acid, CO2, lungs, respiratory. Bicarbonate concentration, or HCO3, is maintained by the kidneys. And think metabolic. Bicarbonate, HCO3, kidneys, metabolic. And that's your base component. So the metabolic and the respiratory processes must work together to keep the hydrogen ion, which is your pH level, normal and stable. And that's what it's all about. It's kind of like the hokey pokey, huh? So you've got your pH balance. And remember, normal pH is 7.35 to 7.45. Wow, that it does not take much to get out of balance. In fact, that is one of the narrowest margins of norms of all the lab values, 7.35 to 7.45. So let's think this again. Carbonic acid, what came to your head? You should have been thinking lungs, respiratory, lungs, respiratory, lungs, respiratory. Bicarbonate, you should have been thinking kidneys, metabolic, kidneys, metabolic, kidneys, metabolic. Those have to get in your brain. So, arterial blood gas analysis. ABG analysis provides important information, again, about a lot of things, but it does not, just getting an O2 level does not help us. We have to know the bicarb level, and we have to know the carbonic acid level. Long before the outward signs of changes in vital signs occur, your pH can have become abnormal. So early changes in vital signs that would be compensatory would be like increased heart rate, increased respiratory rate, and blood pressure until it starts becoming hypotensive as you start decompensating. So blood gas measurements are prime indicators of a patient's changing status. They reflect lung function, lung adequacy, kidney function, kidney adequacy, and kidney perfusion. Again, we're back to our lungs and our kidneys. Blood for ABG analysis is usually obtained from where? Well, the main sites are radial, brachial, and femoral. Radial, brachial, and femoral, with the radial being the most common. If you have a patient who's in the unit and they have an arc line, you can also draw blood from it, ABGs. You only need 3 mL in an airtight heparinized syringe. If it's going to be greater than 10 minutes before getting to the lab, you have to put it on ice. And of course, you're going to have to put extra pressure if you're using the radial brachial area for 5 minutes. And if you're using the femoral artery for 10 minutes after withdrawing from the arterial sites. So the 3 main sites are radial, brachial, and femoral. Do you know what is the Allen test? Okay. This is a test to assess collateral circulation. This is a test to assess collateral circulation. And this is, if you fail to do the Allen test prior to ABG draws, let me go back to that slide. then it could result in ischemic injury to a patient's hand if they have some type of damage to the radial artery that's going to occur. So how do we do the Allen test, the modified Allen test? Okay. Number 1, the client closes their hand into a fist. Closes their hand into a fist. So close your hand into a fist. Let's do this together. Number 2, the nurse occludes the radial and ulnar arteries on the hand that is in a fist. So occlude your radial and your ulnar arteries. Okay? Yes, do this. Ask the patient to open their hand. Open your hand. It should be very blanched color because of the lack of blood, right? Then you, the nurse, will release one of the sides. So release the radial. Yes, release your radial. The color should return in about 10 seconds. Then you would repeat the whole process, except the next time you would release the ulnar side. Failure to increase your color back within 10 seconds means don't use me, okay? You will need to know how to do the Allen test. Measurement of oxygenation. The PaO2 and the SaO2 are used to determine the adequacy of arterial blood oxygenation. O2 measures the amount of oxygen carried in the blood, and SaO2, saturated O2 sat, measures oxyhemoglobin saturation. So the major purpose of evaluating your O2 is to determine the efficiency of ventilation, how well gas exchange is occurring. Your normal O2 is 80 to 100 millimeters per mercury. So 80 to 100. You need to know these. Now, these are norms for a healthy individual who's under 60, whose breathing room at sea level. SaO2, or your O2 sat, is 95% or better is normal. Remember, the O2 only indicates how well they're obtaining oxygen, not the acid-base status. Okay? You do need to remember that. So, your lab book in Chapter 6 does an excellent job of explaining the difference in the PaO2s and the SaO2s. If you don't understand this concept, I would suggest you read Chapter 6 in your lab book. So, when are decreased oxygen levels expected? High altitudes, older individuals, that would be for every year over 60, or those with COPD. I would pick all the above. A patient with chronic respiratory problems may have a low O2 level and can still be adequately oxygenated because of a compensatory mechanism. So if you have a patient with COPD, they maintain higher than normal hemoglobin levels to increase their body's O2 carrying capacity. So their O2 goes down and their CO2 goes up. So someone who's got CO2 is used to having a very high CO2 level. So you come in and you increase their oxygen, let's say, because with the COPD, we should have it at 2 liters or less. You come in and increase it to 6 liters. What have you done? You have wiped out their spontaneous stimulus to breathe. Their stimulus to breathe has become a high CO2 level. Remember, normal was 35 to 45. A COPDer always has a CO2 level anywhere in the 50s and 60s, and they're used to it, and a lower O2 level. So if I come in and increase that oxygen, I'm wiping out their stimulus to breathe and can actually result in death. So you have to be very, very careful. Acid-base imbalances. Cells are very sensitive to changes in pH body fluids. Thank goodness, because remember that narrow margin of normal. Acids are continually released as normal byproducts of cellular metabolism. Carbonic acid, what came through your mind? Should have been what? Lungs, respiratory, lungs, respiratory. Remember, we cannot do it as express measured it, so we measure it in the form of CO2. Bicarbonate, HCO3, what should have come to your mind? Kidneys, metabolic, carbonic acid, lungs, respiratory, lungs, respiratory. So here's the key to understanding it, okay? The pH is the measure of hydrogen ion concentration. And if you look at a scale of 1 to 14, 7 is neutrality. We learned that back in Chemistry 101. But in plasma, The normal pH balance is 7.35 to 7.45. Maintenance of this stable pH is essential to life. You cannot hardly go over or under without getting into trouble. Now that's for arterial blood. Venous blood is a little bit lower. If you think about 7.35 to 7.39, that's not a significant change. But if you think about going from, let's say, 7.3 to 7.5, that's a huge change because it's a change of one whole pH unit. And that represents a tenfold change in your free hydrogen ions. So that's actually a very large increase in hydrogen ion concentration. So you have to be very, very careful if you're going from 7.4 down to 7.3, because that would be a whole increase in pH. Now, maintenance, again, in order to be very stable, we have to have a balance. And that's what your scales are about, that handout I gave you with the scales. If you are looking at that handout, it says 7.35 to 45 is normal. And think about this. In order to have normal, we have to have 1 part carbonic acid to 20 parts bicarb. Carbonic acid, CO2 lungs. Bicarbonate, HCO3 kidneys. If I don't keep that balance, it will not be in the normal. So think about the balance. If I was to take some of this acid off, that side becomes lighter. What happens? Then it goes towards the alkalosis, right? If I was to put more on the carbonic acid side, which is your acid part, then the scales would tilt towards acidosis. So that kind of will help you here in a little bit when we get to talking about the imbalances. So the pH measurement in an ABG analysis assesses the overall acid-base balance. The higher the hydrogen ion concentration, remember hydrogen ions are acids, the lower the pH because it becomes more acidic or acidotic. Because on a scale, the more acidic something is, the lower the pH. The lower the hydrogen ion concentration, in other words, the less acid you have, the higher the pH or the more alkaline. That's just basic chemistry, alkalosis. So the pH reflects the regulation of hydrogen ions within the whole body. Okay? Remember, hydrogen ions are the acid element in a solution. Norms. You must know me. You must know me. There are 3 important norms, and if you know these norms, you can interpret any acid-base imbalance. Normal pH, 7.35 to 7.45. Normal CO2, 35 to 45. Normal bicarb, 22 to 26. Already thinking lungs, respiratory, kidneys, metabolic. The 2 organs which control the acid-base imbalance, kidneys and lungs. So when either one of these organs fail or become impaired, what's going to happen? An imbalance is going to occur. So if something happens with my kidneys, who's got to help out? The lungs. If something happens to my lungs, who has to help out? The kidneys. Okay? So they are partners in crime. When the kidneys fail, the resulting imbalance is metabolic. Kidneys, metabolic. When the lungs fail, the resulting imbalance is respiratory. Lungs, respiratory. Buffers are our first line of defense when something goes wrong. So when that 1 to 20 ratio that we were looking at on those scales earlier goes wrong, buffers kick in. A buffer is a substance that can act as a chemical sponge. It will either soak up or release hydrogen ions. So think of a sponge. You set it down on water. It can either soak some up or you can wring it out. And that's the same way. So it helps maintain that pH to relatively stable conditions. Now, some buffers are present in all your body fluids and act immediately. In fact, within seconds. But react only when there's too much or too little bases in your body or acids. There is a good discussion in your MedSurg book on page 178 that goes over some of the regulatory mechanisms. Okay. Actually, it starts on 177 and goes through 178. You do need to read over those. All righty. The main buffers. You have your chemical mechanisms, your chemical buffers. bicarbonate buffers, and phosphate buffers. These will react rapidly, as well as your protein buffers, which is your hemoglobin, albumin, and globulins. But your two main buffer systems, so those will be the things that react immediately, trying to help you out. But that's only temporary. That's only going to last for a short time. Then we're going to turn to our kidneys or our lungs as our buffer system. And depending upon the system that's broke, the other system will kick in to help, right? This is called the carbonic and bicarbonate buffer system. The carbonic and bicarbonate buffer system. The carbonic, in case it's not drilled in your head already, is your lungs kicking in. The bicarbonate part is the kidneys kicking in. All right, again, we said earlier, the normal ratio is 20:1, right? 1 part carbonic acid to 20 parts bicarbonate. And it results in a seesaw effect if it's not maintained. Or think of the balances, that balance with the scales. The scales will start tilting one way or the other. So if you think of a balanced seesaw in your head, one end with acid, the other with base, and again, I've given you the handout, and I went through this a little bit earlier. If we place extra acids on this side, if I put extra acids, the scale's going to tilt which way? It's going to go acidic, right? Acidosis is going to exist because that pH is going to fall below 7.35. If you're looking at the scales and I put extra bases on that side, so I was to go and put a whole bunch of more bases, the scale's going to tilt which way? Greater than 7.45. So alkalosis is going to exist. So what happens if a pH drops below 7 or raises below 7.8? You rest in peace most of the time. Okay, not a good thing. We don't want to let patients' pH get to this point. We want to be the RN that intervenes through clinical reasoning and prevents this from happening. How do we do that? We learn the signs and symptoms. We know which patients are at risk for which imbalance, and we react on it. Compensation, you do need to know the difference between compensation and correction. Compensation is the effort of the body to maintain normal pH, okay? But it's temporary. So compensation is the effort of the body to maintain normal pH. Correction is the process by which the system, which was not functioning properly, is repaired. And this is long-term. So compensation is temporary, correction is long-term. In compensation, again, the system which is still functioning properly is the one that's responsible for returning the pH back to normal. So, for example, in respiratory acidosis, respiratory acidosis, the lungs are broke, right? The lungs are broke. They've caused an imbalance. Who's going to have to help with this? The kidneys. So the system that's working properly, in this case the kidneys, would compensate by retaining more base or getting rid of more acids, right? Because I'm in respiratory acidosis. I have too much acid. So either I've got to excrete more acid or retain more base to bring that back into balance. So when analyzing ABGs, always check for compensation. You always initially, number one, label your pH. Always. That's the first part. Label your pH. 7.35 or below, acidosis. Above 7.45, alkalosis. So 7.35 to 45 is normal. Anything below 7.35 is acidosis. Anything above 7.45 is alkalosis. Compensatory mechanisms can only be effective temporarily, and you're going to have to cure or treat the cause through correction. So, what is the major effect of acidosis on the central nervous system? Depression or stimulation? And the answer is depression. What is the major effect of alkalosis on the central nervous system? And the answer is stimulation. So if you remember this, it will help you on the test with signs and symptoms, because think about it. If someone's in acidosis, and we know that causes depression of the central nervous system, then don't you think we would see things like disorientation, confusion, leads to a coma if we don't do something, right? Now, these are not written in stone because depending upon the cause, some things can cause an acidosis, some twitching, some confusion. But these are general signs and symptoms you would see. In alkalosis, stimulation. So things like tetany, muscle weakness, convulsions, because think of things being overstimulated. Bicarbonate, you should have been thinking what? Kidneys, metabolic. This is the base component. Again, your book states 21 to 28. We are going by 22 to 26 as the norms. 22 to 26 milliequivalents per liter. This level is primarily affected by metabolic changes, and anything greater than 26 indicates metabolic alkalosis. Because why? This is the base part. So if I've got more of it, I've got more base. I'm going into alkalosis. Go back to the scales, and if you were to add more base, you tilt towards alkalosis. This is my base part. So if I take it away, go back to your scales, it's going to tilt which way? Acidotic. Kidneys, metabolic. So metabolic alkalosis and acidosis. Carbonic acid, you should have been thinking what? Respiratory, lungs. The CO2 is the acid half. So normal range is 35 to 45. Anything greater than 45, I put more acid on there. So respiratory acidosis. Anything less than 35, I've taken away some. So respiratory alkalosis. And if you remember those norms, you can't go wrong. Another way to remember it is Rome, the mnemonic Rome. Respiratory is opposite your pH. So if your pH is going up, as in alkalosis, then your CO2 would be going down. It's going the opposite way to equal alkalosis. If your pH is going down, which is an acidotic state, your CO2 is going up to cause an acidotic state because that's your acid component. With metabolic, they are equal instead of opposite. So with your metabolic part, your pH and your bicarb go in the same direction to cause alkalosis, and your pH and your bicarb go in the same direction downward to cause acidosis. Alrighty then. So let's see what else we've got here. We've got a little scenario. It says the respiratory system reacts to changes in the kidneys within minutes. In other words, it's not going to take us very long to increase or decrease our respiratory rate. And this is effective in correcting imbalances about 50 to 70% of the time. If metabolic acidosis occurs, okay, let's think this through. Metabolic, kidneys, acidosis, too much acids. Metabolic acidosis occurs. Who's going to kick in and help? The lungs. How are they going to be able to help? Well, I've got too much acid, right? How are they going to help? Hyperventilations. Why? That's going to blow off CO2. What's CO2? Acid. I've got too much acid. I'm going to blow it off. If metabolic, kidneys, alkalosis occurs, too much base, the lungs will compensate by hypoventilations. Now I'm going to retain more of the acid. Instead of getting it out, instead of increasing my respirations and trying to get off the acid, the CO2, now I want to hypoventilate and retain more of that CO2 so that I cause this to balance, because now I've got too much base. So with the kidneys, they react to changes within the lungs in hours and days. So they're not as helpful as the lungs, because the lungs can increase and decrease respirations within minutes. But it's going to take a while for the kidneys to help out the lungs. So if respiratory acidosis occurs, oops, something's wrong with the lungs. I have too much acid. How can the kidneys help? Well, they can either excrete hydrogen ions, which is acid, or retain more bicarb, which is a base. If respiratory alkalosis, oops, something's wrong with the lungs, I have too much base, then the kidneys are going to have to help by either conserving more acid or getting rid of more base to bring that back into balance. So there are 4 major imbalances: metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. All right, in metabolic acidosis, the major imbalances you need to remember these. There are two major causes for metabolic acidosis, either an increase in acids or a decrease in bases. An increase in acids or a decrease in bases. This is not a disease, but a condition caused by a disease or a pathological process. So these are not diseases. These are conditions that are caused by a disease. Think of your scales again, okay? So the two main causes is either an increase in acids, right? Metabolic acidosis. I put more on the acid side, or I took away from the base side. That's the only thing that can cause metabolic acidosis. So I can either have an increase in acids. The common causes would be like DKA, poisonings, lactic acidosis, or renal failure. I have made you a sheet, common causes of imbalance, a handout. Know it inside out. There are several questions on the exam about it. Memorize it. Decrease in bases. What would cause that? Diarrhea, intestinal suctioning, pancreatic drainage, drugs, some drugs, and renal tubular acidosis. Renal tubular acidosis is when the renal tubule cells are unable to reabsorb bicarb. Well, if I'm not reabsorbing bicarb, I'm losing bicarb. Okay? So let's just look at a couple of these. Think about increases in acid. DKA. Okay? With DKA, glucose is unavailable for energy, sugar, right? So what's the body going to use? Fats and proteins. Well, when I break down fats and proteins, I get ketones and amino acids, and everything gets very acidic, okay? Poisonings, think about poisonings, aspirin, alcohol, all that breaks down into acids. Renal failure, you get uremia, that's the end products, okay? So someone who goes into renal failure builds up uremia, the end products, they go into acidosis. How does diarrhea cause a decrease in base? Well, your lower GI system to begin with is alkaline. So if you take the alkaline part away, that makes it more acidic. Okay, it's a loss of base because you've got to think about what you're starting with to start, what your environment is of the pH to start with. So signs and symptoms of metabolic acidosis would be things like lethargy, Cushing's respirations, hypotension, clamminess, a general depression of the central nervous system. Now, if you look in your book, there are key features to acidosis on page 181. Key features to acidosis on page 181. You do need to know those. Treatment. What is treatment of metabolic acidosis? You've got to treat the cause. For example, going back to that list logo, if the cause is diabetic ketoacidosis, then you're going to have to treat the DKA. If I start giving insulin and I start giving fluids, then the signs and symptoms are going to reverse. That would be correction. Okay. Here's you a little thing if you learn by that way to help you with the signs and symptoms as well. This Cushing's respirations is a compensatory mechanisms where we're hyperventilating short, rapid respirations, and that's to help blow off that CO2. That's very normal in a patient that is experiencing metabolic acidosis. You would expect to see Cushing's respirations. Metabolic alkalosis, two main causes, increase in bases or a decrease in acids, just the opposite of what we talked about. Think about the scales. So an increase in bases, what would be the cause? Well, one would be administration of excessive sodium bicarb. Okay, so if I'm taking in too much sodium, I'm going to have an increase in bases. So these little old ladies who take in a lot of Tums, Alka-Seltzers, things like that, have an increase in base. A decrease in acids could be through a loss of hydrogen and chloride through vomiting and nasogastric suctioning. A decrease in acids. Why vomiting? Because I started with an acidic environment in my stomach. And if I start losing those acids, that causes a decrease in acids. Okay, diuretics, some of your diuretics can cause it, and some of your syndromes such as Cushing's. All right, so what is the signs and symptoms of metabolic alkalosis? Central nervous system stimulation overall, so think twitching, rapid deep breathing, nausea, vomiting, headaches. There is a chart in your book on page 184 that goes over the key features of alkalosis. Make sure you know those. So what's the treatment for metabolic alkalosis? Treat the cause again. For example, if they're vomiting, treat the vomiting and keep them from vomiting. Okay, so it's always treat the cause. Here's you another picture for those of you who like these that goes over the signs and symptoms of metabolic alkalosis. Respiratory alkalosis. The main cause is hyperventilation. Why? I'm blowing off too much CO2. Therefore, I'm going to result in alkalosis. So what causes hyperventilation? Well, hypoxia, anything that causes hypoxia, PE, pulmonary emboli, severe exercise, that would be me, shock, restriction of the diaphragm, anything that causes that. Some medications, ventilation, trauma, fear, pain, anxiety. We all know we start hyperventilating sometime. And then actually correction of acidosis, metabolic, can throw you into respiratory alkalosis if you overdo it. Signs and symptoms of respiratory alkalosis are the same as we talked about earlier with metabolic alkalosis. The tingling, the dizziness, lightheadedness, and if you know the key features of alkalosis on page 184, you'll be fine. So how do we treat respiratory alkalosis? One thing we can do is breathe in a bag. If they are anxiety, that rebreathing, the CO2, will correct that. Sedation, but it always boils down to treat the cause. Here's you another little picture that may help you. Respiratory acidosis. The main cause is just the opposite, hypoventilation. Okay. The causes are lung disease, COPD, asthma, and CF. Limitations would be to the chest wall and diaphragmic movement, so anything that causes like rib fractures, neuromuscular disease, severe obesity, pregnancy, all of those could cause limitation of chest wall movement, resulting in hypoventilation. Central nervous system depression, like brain injury, drug overdose, anesthesia, and carbon monoxide poisoning can cause hypoventilation, or overcorrection of metabolic alkalosis. Signs and symptoms of respiratory acidosis is confusion, increased heart rate, headache, diaphoresis, lethargy, and depression of central nervous system. Again, if you know the signs and symptoms, the key features that are on page 181, you'll be fine. So how do we treat respiratory acidosis? Again, we go back and we treat the cause. We have to be very careful. It may be bronchial dilators and opening them up. We have to be very careful about watching with narcotics because sedatives and narcotics in patients with acidosis can make the acidosis worse and actually lead to, rest in peace. So we don't want to be that nurse who does not critically reason, critically think. I have someone in respiratory acidosis, right? They're already hypoventilating, so I have to be very careful with narcotics. And there's another picture if you want to go by the pictures. So let's put it all together, okay? This is what you need to know to interpret any APG. pH, what was the normal? 7.35 to 7.45. Anything greater than 7.45 is alkalosis, too much base. Anything less than 7.35 is acidosis, too much acids. So this is hydrogen ions we're talking about here. Either we got too much hydrogen ions or not enough hydrogen ions. Bicarb. What'd you think? I thought kidneys. I thought metabolic. Normal, 22 to 26. This is my base part. So if I have more of it, I'm going into alkalosis. If I've got less of it, less than 22, I'm going into acidosis. CO2, that's my acid part. My acid part. I thought lungs, respiratory. Normal's 35 to 45. So if this is my acid part, if I've got more of it, I'm going into acidosis. If I've got less of it, I'm going into alkalosis. So in acidosis and alkalosis, if you think about alkalosis, you're kicking the pH up. And in acidosis, you're sliding the pH down. So can a patient have mixed acid-base imbalances? And the answer is absolutely. With a COPD patient, for example, the underlying disorder of respiratory acidosis may be complicated by metabolic alkalosis if they're taking diuretics, if they're taking steroids. So yes, it is very common a lot of times to see mixed disorders. Usually an electrolyte imbalance will also coexist with your acid-base imbalance, especially potassium. Hyperkalemia is common with acidosis, and hypokalemia is common with alkalosis. Your book does a good job of explaining that on page 182. If you're looking on page 182, it shows you under normal conditions, the intracellular potassium content is greater than that of the extracellular. So there's more in the intracellular than the extracellular. The concentration of hydrogen ions is low in both. Okay. Now, what happens then if acidosis occurs? Well, if acidosis occurs, the extracellular hydrogen ion concentration increases. So you get more in the extracellular fluid compartment. Okay. That will cause the hydrogen ions to move into the intracellular, trying to balance it out. So when it does that, an equal number of potassium ions leave the cell. So then you get into hyperkalemia as it's going into the cell. In alkalosis, more hydrogen ions are present in the intracellular fluid compartment than the extracellular. So hydrogen ions now are going to move from the intracellular to the extracellular to keep the intracellular fluid neutral. So potassium ions now move from the extracellular into the intracellular, causing hypokalemia. Okay. So what are some common nursing diagnoses that you're going to see? You're going to see ineffective breathing pattern, impaired gas exchange, sensory perceptual alteration, tissue perfusion altered, anxiety, fatigue, risk for injury, decreased cardiac output, fluid volume deficit. And one of the big things that you've got to learn as an RN is that you can help optimize respiratory and renal function by doing certain things. For example, positioning. That can help with oxygenation. Pulmonary hygiene, making sure that you're suctioning, keeping their airway clean. Hydration, decreasing anxiety, medications, O2 therapy. So there are things you can do to minimize and prevent these imbalances from occurring. Now, there are some sources of error that can occur when you're collecting your ABGs. You can get air bubbles that increase the O2, the CO2, and that decrease the CO2 and increase the pH. In a venous sample, you can accidentally get one of those, and that's going to mess it up. Anticoagulant effects can cause decreased pH, and if they've got a fever, it increases the O2 level. Okay, so these are things that can go wrong with your sample. So are we finally ready for ABG interpretations? Sure we are. What did I say the first step always was? Label the pH. Label the pH. Anything less than 7.35 is acidosis. Anything greater than 7.45 is alkalosis. Number 2 is always find the cause. Well, it only has 2 culprits. It's got to be metabolic or it's got to be respiratory. If it's respiratory, something's wrong with the lungs. If it's metabolic, something's wrong with the kidneys, right? And the third step, which is a little bit harder, is check for compensation. Is the system that's not broke kicking in to help the system that is broke? And the best way that I have learned to do that is to play tic-tac-toe 3 in a row. Okay. So at this point, we're going to go over an overview of the article. So if you will get your article out, tic-tac-toe 3 in a row, we will go over this. So you will need to set up a grid. First of all, number 1, it says you have to know your norms. So your pH norm was what? 7.35 to 7.45. CO2, is 35 to 45, and that's your acid component. Your bicarb, HCO3, 22 to 26. So you've got to know your norms. Then set up your grid like on page 38 of your article. Okay, so look at the grid on page 38 of your article. That's how you're going to set up these. You're going to put acid, normal, and alkaline across the top. Then you're going to go draw 2 boxes under each one of those. Okay. There's also a good box on page 38 that reviews the causes of acid-base imbalance. So, acid-base interpretation is going to be very fun. There are also some at the end of the email. I've given you some extra ones to help out. You want to email those to me. Once you've done them, I'll be glad to go over it with you. So get your article out and let's work through this, okay? The first part just goes over everything I pretty much just went over. So if we go to page 38 of our article, okay, and where it says Robert Miller, for instance, right above the chart causes of acid-base imbalances, for instance, let us consider the case of Robert Miller, a 70-year-old diabetic who has a long history of not taking his insulin. He has just been admitted to your unit and you received the following ABGs. 7.26, CO2 42, bicarb 17. You then have to plug these into the 3 parameters into the grid. Okay, so let's look at our grid here. pH 7.26. Okay, that's below 7.35, so that's acid. So I would write pH below my acid. CO2 normal is 35 to 45. That falls in my normal range. So there I have to put my CO2. Normal HCO3, 22 to 26. This is low. Now I have a lot lower. Remember, this is my base, and I've got two less of it, so that goes into the acid part. So now I've got bicarb written under that. When you get 3 in a row going downward, you're ready to diagnose your patient. In this case, Mr. Miller has what? pH is under acid, so that's acidosis. And it's HCO3, think kidneys, think metabolic. Metabolic acidosis, okay? So this patient, Mr. Miller's in metabolic acidosis. Well, he's got a long history of not taking his insulin, so he's probably went into DKA. And if you look down at the bottom, one of the causes of metabolic acidosis is DKA. So anytime you have a diabetic not taking their insulin, you always think they can go into metabolic acidosis. Now, the final thing you always want to look at is, are they compensating? So there's 3 ways to determine if someone's compensating. One is if it falls in the normal column. So if you ever have something in the normal column, the CO2 or the HCO3, there is no compensation. Why is there no compensation? Because it's not doing anything to compensate, okay? So if either one of them, the CO2 or the bicarb's in the normal, then it is no compensation. So going back to Robert Miller, let's go back and diagnose him again. His pH is under acid, acidosis. Bicarb is under acid, so it's metabolic. Metabolic acidosis, and his CO2 is under normal, so no compensation. Okay. Now let's look at Elizabeth Silver. She's in the last on the right-hand side. She was brought to the ER following an auto accident. She sustained no injuries, but she's extremely upset and anxious. She's been breathing rapidly since the crash and now feels faint. Her ABG results are 7.49, CO2 of 30, and bicarb of 23. So you would plug these into the grid and you would get pH is 7.49, that's alkalosis, so it goes under the alkaline. CO2 is 30, that is 35 to 45, this is your acid part, so you've got less of it, so it's alkaline CO2. And then your bicarb, 22 to 26, this is normal, so it would go in your normal column. You have 3 in a row, you're ready to diagnose your patient. Their pH, number 1, it's always labeled a pH. It's in the alkaline, so alkalosis. Number 2, what's the cause? Is it metabolic or respiratory? In this case, it's your CO2, so it's respiratory. Respiratory alkalosis. In the third step is always, is there compensation? Is there one in the normal column? Yes. Your bicarb is in the normal column. It's not doing anything to compensate. So you're ready to diagnose your patient, and your patient has respiratory alkalosis with no compensation. That makes total sense. They're extremely upset and anxious. They're hyperventilating. If they are hyperventilating, then they are blowing off too much CO2, and they're going to go into respiratory alkalosis. There are 2 other examples on the next page, on page 39, that I want you to look through. But the last thing we're going to do, I want you to look at a couple of these. When you're looking at Luis Ramirez, is a 64-year-old patient, I'm on page 39 of your article, who has a long history of COPD. Okay, COPD, I'm already thinking respiratory acidosis. His pH was 7.26, that's acid. His CO2 was 52, that's greater than 45, that's acid. And his bicarb, 22 to 26, this time his base is up, so it goes under alkaline. Well, look what's happening here. We know the patient, number 1, label your pH as acidotic. Find your cause, metabolic or respiratory. We know it's respiratory acidosis. But look at your bicarb this time. It is not in the normal column. It's opposite. So it's trying to do something to help. So in this case, when you've got the CO2 on one side and the alkaline on the other side with the pH in there, then you are in partial compensation. So if either one of them's in the normal, it's no compensation. If they're opposite each other, it's partial compensation. So in this case, partial compensation. If you look down at the next case, Kate Donnelly, her pH was 7.48, so that goes under alkaline. Her CO2 is 51, that's acid. And her bicarb's 29, that's alkaline. So you have you have alkalosis, metabolic alkalosis, and its sea salt effect, it's opposite, so you have partial compensation. The last thing that you need to know is, oops, what if the pH is normal? If the pH is normal, then they are totally compensated. So you've got 3 choices with compensation. You've got no compensation, that would be if the CO2 or bicarb falls in the normal column. You've got partial compensation if they are opposite, one under the acid, one under the alkaline, or you have complete compensation. The only time you can ever have complete compensation is if you start with a normal pH. Normal and no compensation and partial, you always start out with a abnormal pH. So let's look at Greta. She's in the middle column on page 39. Greta, she's 45. She has myasthenia gravis for 5 years. She was admitted complaining of dyspnea even at rest. And here's her ABGs. 7.36, okay? That's normal, 7.35 to 7.45. So, oops, what do I do? Well, if you go to looking at 7.35 to 7.45, what's right in the middle? 7.40. 7.40. So if you start out with a normal pH, you're going to have to put 2 pHs in your little grid. Anything since 7.40 is right in the middle. Anything less than 7.40 is acidosis. Anything greater than 7.40 is alkalosis. So hers was 7.36. That's less than 7.40, so it goes in the acid. So you would put pH 1 acid, okay? pH 1 acid. Actually, you would put pH 2 acid. Your pH 1 is in the normal column. So pH 1 was normal. Your pH 2, you broke it down even further and went under acid, okay, because it was below 7.40. Then you have to look at your other values. In this case, the CO2 is 50. That's increase in acid, so your CO2 goes under the acid part. Your bicarb's 34. That goes under the bicarb part. And if you were looking at it, you're thinking, well, it's sea salt, so it's partial compensation. No, you have a normal pH. If you have a normal pH, you don't even have to worry about compensation. You know it's complete before you even answer it. So in this case, the patient has respiratory acidosis with complete compensation. All right, If you have any questions, please read through this article very carefully. That is such an easy way to do it. And if you go that route, you will not forget it. Okay? After reviewing this content, I still need help, then you need to call me because we need to work through this one-on-one to make sure you understand it. Give me a call. We'll set up a time, and we'll go over this till you do understand it. So, tic-tac-toe, 3 in a row. Again, you want to do write out your grid like in that page 38. Always follow your steps, label your pH, determine the cause, and then see if there's any compensation. Practice makes perfect. So let's work one together, okay? So make your grid. And I have written across my grid acid, normal, and alkaline. Or you could do acid or base or acidosis, alkalosis, however you want to do it. Okay, once I have my little grid made, then I'm going to look at my ABGs. 7.23. Okay, that's below 7.35, so I know it goes under my acid column. So I write my pH under my acid. It is not a normal pH, so I know I do not have complete compensation. That leaves two choices, no compensation or partial. My CO2 60. Okay, so my CO2 level is high. That's my acid, so I'm going to write CO2 below my pH. My bicarb is 24. Normal is 22 to 26, so it's normal. So I'm going to write my bicarb in the normal column. So if I look at this, I'm ready to diagnose. I have 3 in a row. Label my pH. It's under acidosis. Tell the cause. It's CO2, so it's respiratory. Respiratory acidosis. And then if I look, it's in the normal column with no compensation. If you didn't get respiratory acidosis, no compensation, you're one of those ones that need to call me. I want you to practice these 1 through 5. Send me an email so I can see how you're doing on this, and I will follow up. Thank you very much. Have a good evening and hope you have enjoyed respiratory ABGs and that it has been a little bit of fun. Okay.